This conference will now be recorded.
All right. Good afternoon, everyone. Let's go ahead and get started. I want to kind of keep everyone on time. And I do have a schedule here that we're starting at basically, I guess, from that clock at 12:45. And we'll try to get done by 3:15. As you can see, we have several topics that we're going to be discussing. And I guess you don't have a laptop. Some of you have a laptop. Do you have this pulled up on your laptops? Oh, okay, great. So I'm Dr. Winn. I'm a faculty physician, Department of Family Medicine at OU. I've actually been there about 30 years. So I specialize in family medicine, geriatrics, hospice, and palliative medicine. I am a medical director for Mercy Hospice, and I'm also medical director for a long-term care facility. And for those that are online, I do have a handout here that I've handed out in the room, and I'll give copies of this to Z that you can pick up next time you're in the office from him. So thank you for having me. Excuse me. Actually, I think I've given this 8 or 9 times. It's twice a year, so I've been doing it a while. And this is kind of a challenge. I usually ask what everyone is, as far as the occupation, excuse me, right now. So just very briefly, let's go ahead. Amber, what background are you from?
I am from the nursing home, and I have business office and human resources.
Okay, and next?
I am the director of marketing and admissions.
For nursing home, and
Acute care hospital administration, 20 years, plus post-acute rehab, long-term acute care.
okay, good.
I'm like him.
Yeah.
Same thing, acute care hospital, mainly rural health, ambulatory surgery centers.
Great.
Radiology supervisor for Ascension St. John.
And so you're wanting to become an administrator?
I have my master's in healthcare administration. And I was actually recommended to get into this, so here I am.
Okay.
I have no current background.
Okay. Interesting.
Just getting in.
Getting in, tipping your toes to the water kind of thing. And you?
I work in a nursing home. I studied as a CNA and CME office manager.
Okay. And Michelle?
I am a social worker at Spanish Cove.
Spanish Cove, yes. Been around a long, long time. Yes, and you?
Assistant director of nursing / infection prevention.
Yeah, perfect. Okay, that's great. So actually, this is a little bit more similar, I guess, in many ways. We have people have been speech therapists in the past, and occupational therapists or physical therapists who have kind of getting into this. A lot of you have kind of been in this area of long-term care continuum already, obviously. So that's great. That's great. So let me go ahead here. I'm sorry, I'm on call for 3 different organizations right now. So maybe a little bit briefer, but I think the main goal of what I want to do is kind of give you a flavor of what a medical director can be for you at your facilities where you're working, whether they're there now or whether in the future, because there are expectations more and more, even through regulation, that the medical directors of any kind of long-term care facility or skilled or rehab would be more involved than they have been. And there's a big variation in the amount of involvement that physicians may be in kind of continuum. As you know, in Oklahoma, you don't require a medical director for assisted living, okay? But we do for skilled and long-term care nursing facilities. That may change. I will say I've been in long-term care 30 years, and I will say that the patients that I'm seeing in assisted living are as complicated as certainly some of the nursing home residents that we see. And certainly from 20 years ago, the nursing home used to look like assisted living. In fact. So as you may be aware, we have a lot more sicker patients on a lot of different medications, seeing a lot of different specialists. And of course, it's going to depend whether they're in acute rehab or whether they're long-term care. And of course, there's the transitions in care that are very important. And also, as you may be aware of, the cost of care. So people and the government, like Medicare and Medicaid, want to have our patients do better and have a higher level of satisfaction, higher level of function when they leave the facilities, and that's family members being satisfied, and all of this at lower cost. There is a limited amount of money for healthcare, as you may be aware of. So let's go ahead. Again, I apologize. There's no screen in front of me here, so I'm going to have to look back once in a while just to kind of see where we are. So I have no relevant financial relationships in the manufacture of any commercial products or provider of commercial services in this presentation. I will discuss some information, some books and that type of thing that I've worked on, but I'm not trying to sell you these books. What I'm trying to do is introduce you to some of these books that you could suggest that your medical director get hold of and review. So I have been working at the national level with the American Medical Director Association, which is a society for post-acute long-term care medicine. I've been with them probably 20 years. I don't get any pay for what I do. I've been on the board, the foundation board. I've been on what's called the CMD, Certification Medical Director Board. And I also teach what's called the CMD course, Certified Medical Director course, and administrative aspects in post-acute long-term care. So that's kind of where I'm coming from at the national level. I've also been, in the past, I've been on the Long-Term Care Facility Advisory Board through the Department of Health. And I was on that for like 12 or 15 years, and I got off that about 6 or 8 years ago. I trained in Canada, and I'm also board certified in family medicine in Canada as well as down here. Sorry, I'll let that go. Yeah, it went the wrong way. Oh, it's upside down. Okay. All right. So I'm going to be talking about the 4 key roles of medical director in post-acute and long-term care as defined by the Society for Post-Acute and Long-Term Care Medicine. We're going to talk about infection control. And there I have 3/4 of an hour to work on that because that is an important area. As you may be well aware, when COVID-19 came in, they stopped doing the annual surveys earlier last year. I think in March, they stopped doing the annual surveys and we're doing infection control surveys alone. And then they've also been following up on those in addition this year. Talk a little bit about standards of practice. Always a little bit unclear. As a physician, I kind of know what my standards of practice are. As far as you folks, when you're long-term administrators or if you're a nurse or physical therapist, you have your own standards of practice. A lot of this is guided by legislative bodies, state government, and then some of the boards. So I'm just going to, that may be all I say about it, depending on our time. And then looking at quality assurance is going to be important, what we call quality assurance performance improvement, or QAPI. And then off and on, as we go through these different areas, I may allude to some difference between assisted livings and nursing facilities, one of which I've mentioned already. Here in Oklahoma, assisted livings do not require a medical director. They may want to do that if they want, but there are other states that may require a medical director of an assisted living facility. Again, they have a lot of medical problems, and you may not be here in Oklahoma, in 2 or 3 years' time. You may be in another state, so the regulations for you and the requirements and training that you need may be different. Okay. All right. So this year, meeting the leadership challenge in long-term care. If any of you have a phone now, you can probably Google that and see that. It's by David Farrell, and actually we're a medical director of a long-term care facility. I actually gave one of these books to the administrator who actually went through this course about 3 or 4 years ago. I gave her a copy of that. And there is a second book from this David Farrell looking into more aspects of administration. I think it was, and I didn't bring it with me. It's in my office downtown. But you could see it's the same author, but it's kind of a part 2 in a sense, or going from 100 course to a 200 course. And I would encourage you to read that. Those are very helpful. I think they run about 30 or 40, probably no more than $50 a copy. So I would encourage you at least to get one or the more recent one that they've published. And I haven't been involved with that. There's various journals that you may want to be aware of, Annals of Long-Term Care. Of course, there's the journals for the nonprofit and for the profit long-term care / assisted living, the American Health Foundation or American Health, the AHCA, I think, and then there's the for-profit and non-for-profit. Also, another journal that you may get to you, this often is available online. I still get a hard copy, but I think they've stopped getting the hard copy. But you can get emails from them with up-to-date information on what's going on in your facilities. There's another one, a provider, and this one is from the American Healthcare Association, which is the for-profit long-term care nursing home. And so you may want to see that. And there's some good articles in there. I like to look at these articles because they give me information as far as medical director, what's going on in your field. So I'm hoping to let you know what's going on in my field because we do work together. There's another book here. This is more for physicians. This was put out probably 15, 20 years ago, Medical Direction in a Nursing Home. And you may say, oh, that's old. What was discussed in this book is actually what's going on now, okay? It was very futuristic and is right on. There's a Dr. David Petit that put that together. So again, something, and it does discuss the team, the role of the administrator, role of the DON, that type of thing, and the role of the medical director. And then there's this one here, Post-Acute Long-Term Care Medicine. Was the second author or editor for this. It's actually that second edition, and we're just doing a third edition now. This one came out in 2016, and again, I'm not trying to sell this. You know, the hours and hours and hours that the editors put into this book is like probably getting paid, you know, as far as royalties, $2 an hour. So, but we're working on the third edition, which hopefully will be finished sometime in the summer and be out probably next year. So we're waiting for the final acceptance. But again, this is really helpful. This is a primer, basically, for nursing assistants, clinical nurse specialists, PAs, nurse practitioners, physicians who are coming into your communities and seeing patients or seeing your residents. It's not specifically for medical directors, but we do have medical directors who are authors for the chapters. There's actually 19 chapters. There's going to be 21 because the new things that have come up is the COVID-19. We're going to have a chapter on COVID-19, and we're going to have a chapter on virtual care and telemedicine / telehealth, which is a big thing right now in long-term care that's coming. Excuse me. Okay, so I already alluded to this here, the Society for Post-Acute Long-Term Care Medicine. How many here have heard of AMDA? Just one, okay. Two? Well, hope you do. So there's a lot that they do. Just go to their website. Again, it's paltc.org. Okay. And so their vision is a world in which patients and residents receive highest quality, compassionate care for optimum health, function, and quality of life. I was looking at this last night, and I said, that's the whole goal of what we do in healthcare. Doesn't necessarily mean their blood sugar is this or that, or their blood pressure is this or that. Basically looking at function and quality of life. And what do you think the surveyors are coming in? Okay, they're looking at make sure that the residents you see are getting adequate health care, that you're trying to optimize the level of function that's occurring and try to prevent functional decline and have a good quality of life in the facilities. And obviously that's been a very major concern within the last year when we have people being isolated in the communities, families not able to visit. The facilities may differ on how they work with families and family members. So for example, when I left the nursing facility where I was this morning, I saw a family member still outside the window talking by telephone to the loved one inside. So, sorry about that. So again, it's what you need to know, but afraid to ask. I mean, we all learn from each other, and I hope that your medical directors that you have in your facilities are going to be good teachers, help you understand why they have certain desires or preferences, especially help you with the other areas that we're going to be talking about, infection control and quality assessment performance improvements. Very, very important to know that and help you with that. So, I was going through, we actually just had a copy, and this that I give you is not related to our copy. It's a copy that we use at the national level as an example when we're teaching medical directors in training as far as their leadership and administrative skills that are expected at this point in time. So we were talking about, lab tests, and actually had a lab that was sent to me probably over Friday night. It was faxed to my office. Okay. And let's see, I'm trying to remember, there were two instances. One of them was a urinalysis with a high white cell or count in the urine indicating a probable infection. So in theory, okay, they faxed it to my office. They also faxed it to the wrong fax number. So I didn't get it till late Monday afternoon or Tuesday. Where I work, we have 50 doctors in the clinic, okay? And I have a specific fax number that comes to me, but I wasn't in the clinic Saturday or Sunday. I just finished being on hospital duty for a week. There were two faxes with lab that needed immediate attention, but they didn't get immediate attention. And so I brought this forward to the quality committee yesterday, and I said, I have given you this list about what blood tests, if they're abnormal to a certain degree, don't just fax it and get monkey off your back and assume I'm going to get it Saturday morning and do something about it. I'm going to get it, right? And so when I brought my list forward, I said, look, I gave you guys this like 8 or 10 years ago, and I had a pharmacist, PharmMD, doctor of pharmacy, with me, and we went over it this morning. He's helping me out. And he looked at it, I said, yeah, that's all relevant. That's all relevant. It's less than this or greater than that. So I gave that to the ADON and said, hey, you need to do an in-service on this because we need to prevent this from happening. You have a white count of over 100 or 100, over 100 in the urine, that person could become septic, could have to go to the hospital, and potentially even die if they were seriously ill. So, we try to prevent hospital admissions. Doesn't mean we're going to not send people to the hospital. But, we got to provide good care. Where I am, we're at a 5-star, or a 5-star India. And so I don't want to lose them. We're actually in the survey window as well. I'm just saying, you've got to be ready for this. All right. We'll come to that. So medical director is seen again as an administrator of the course that I teach, which is basically the only course available in the United States, is through the organization that I mentioned. It's all online now. There's 2 big parts. It's all taken online. And then actually, we used to have what's called a synthesis weekend, which starts on a Friday, goes through Sunday. But we actually just did that this last July when we did the breakout groups, all virtual, all virtual. Okay. So 4 key roles: physician leadership. Being a medical director is just not seeing patients. Okay, we want them to be involved. In fact, according to the regulations, you need to be involving your medical director in your decisions, okay, and reviewing your procedures and processes. So, physician leadership. Sorry, wish there was a screen in the back. So, overseeing physicians and other healthcare providers in the facility. Okay, so helping the CNAs, the physical therapists, the occupational therapists that come in. We do have a certain responsibility related to that. A lot of it's contracted, right? But as the medical director, they do and should have some form of review of other people that are coming into the healthcare, the lab, the dentist, the podiatrist, the other physicians, the PAs. It's all inclusive. And if your physicians aren't involved, the expectation will be the medical directors to be involved in that. Survey, very important. So we went through QAPI yesterday. it was kind of a quicker one. It was like 45 minutes. We do them every month. And the person who was leading it said, okay, we're done. I said, hey, I got some questions here. And there were some really important issues that came up. We went another 20 minutes, one of which was how to handle this information as far as lab test results and x-ray results. That's really important. Plus also, we're in the survey window. We're actually at 13 months. It's 12 plus or minus 3, right? 9 to 15 months, they're usually going to come in. And so I said, they're going to be coming and they're going to know as far as any deficiencies you had last year, they're going to come and see how you're doing on those deficiencies. It's all in the past, but it's ongoing. It can be ongoing. And what did you have any complaint surveys? And yes, we had some complaint surveys. All of them were unsubstantiated, so that's good. The ombudsman hasn't been around at all. We usually come, but I guess with COVID in the last 12 to 15 months, we haven't had the ombudsman come through. So let's see. So patient care and clinical. Yeah, patient care and clinical. Oh, yeah. Okay, good. So, that's important. And again, I kind of alluded to this already, so I'm not going to be repetitive. And what's really important is that patient care is person-directed, and very important is resident rights. If you look at the F tags, I think has anyone kind of from the Department of Health come through yet? Talked a little bit about the F tags and given you that sheet that lists them all, and it's 2 sides. Well, hopefully they will, but there's probably about 15 or 20 areas in the regulation related to resident rights. Okay? So, for example, the right to choose the physician of their choice, the right to have visitors, the right to work at the gift shop. If they're going to work at the gift shop, they have the right to be paid versus, okay, we're not going to pay you, but you can do it. And there's all a right to vote, right to have access to a phone, to communicate with family, things like that. There's a lot of things to be looked at. And again, looking at personalized care, person-directed care, the surveyors are going to be looking at this. This is kind of a person-directed care is all inclusive. So it's a wide area. That's what they're going to be interested in. Are your residents getting personal, appropriate, personalized care that's directed either by the resident you have or by the family members or the surrogate decision maker or power of attorney? All very important. Quality of care, safety issues, risk management. That all kind of makes sense. But when I go around and if I see a socket that doesn't have a faceplate on it, that's a safety issue, right? You don't want some little kid running around or someone to put their finger close to the socket and it's not covered. So, and then also things like oxygen, making sure that it's appropriately cared for in a safe area. Obviously, a big area is the kitchen. They'll look at that. The quality of care really is very important. A lot of different things to different people, but that's what the surveyors are going to be becoming. And not to say that in a sense, I guess, the surveyors is the tail that wags the dog, but I really don't. I want you to go above what the surveyors are expecting. Okay, we talk about the minimum data set, the MDS, right? Heard about that? Well, that's minimum data set, minimum amount of information. Actually, it's good geriatrics because, as I said, when we take care of patients, it doesn't matter necessarily what their blood sugar is, what their blood pressure is. But the level of function is important. You can say, oh, their blood pressure is really, really high. Let's give them this medicine to bring it down. And all of a sudden you have someone who's lethargic and falling down and break a hip. So there's that's the balance that you need to be looking at. So I do geropsych medical consults at Edmond Hospital. As a geriatrician, I'm very careful about what medications I'm going to give and the doses in them. And we're going to be talking about quality assessment insurance. I think that's still what it is in the book. as far as the regulations go. But from that is the QAPI. My understanding is Medicare doesn't like us to call it QAPI, they like to call it QAPI. And then there's state and national standards. Then looking at staff, I mean, we need to look at the quality of care that's being administered by clinicians. Need to be looking at admissions, discharges, transfers. I've had surveyors come in and say, show us, again, I've been medical director of different places for like 25, 30 years. They'll come, okay, show us the admission packet that you give the family members or someone when they come in. And that, you know, this is a while back, but surveyors can be really, really strict in Oklahoma. And I'm not sure that you're aware of it, but I call it the Van Meter syndrome. We just discussed this with some of the students today that I work with. Van Meter was the head of survey agency and Department of Health. And as you know, surveys are supposed to be not notified before, right? And what was happening is facilities were getting notified beforehand, or surveyors are coming in a week or 10 days, and then the deficiencies would come up and say, okay, this deficiency, we can lower the level of that deficiency, money under the table. And so there was a whole cleanup of the Department of Health survey agency about probably about 20, 25 years ago. At least one person went to federal prison. So, you know, and I'm sure that, you know, your field that you're in, you need to be aware of the regulatory aspects of your jobs. You need to be able to understand the political factors that can impact long-term care and the residents you're taking care of. You have economic factors. Obviously, you're going to be involved in budget, and you know, whether you're a for-profit or non-profit. Even non-profits have to make a profit, otherwise they go away, right? Unless they have foundation money coming in. So something to ask of where you're going to be working is, what's the vision of the facility where you're at? What's the mission? What's the values? Something to ask. And certainly let your medical director say, hey, this is our vision, this is our mission. Short Spanish Code probably has that, and we certainly hope that medical directors out there would know vision, mission, and values. I work as I said, a medical director for Mercy Hospice. I'm not Catholic. I said, do you sure you want me to be your medical director? And, but I'm familiar with the vision and the mission and the values of the Mercy system. I can work through that. Okay, so a little bit about the regulation. There's the FTAG 841. Anyone talk about FTAG 841 to you yet? Okay, well that's the area in the regulations that talks about the role of the medical director according to the national laws. Okay, so first of all, facility must designate a physician to serve as medical director. Okay. I do remember probably 35 years ago, I've been in Oklahoma since '85, that I went to I guess, for-profit or non-profit national meeting, or at least state meeting here. And there was a person there who was not a physician, and they were the medical director of their facility. That's all changed. Has to be a physician. And then,
What kind?
what that?
Does it matter what specialty?
You have to go for medical director. You have to be a physician.
Correct.
Yeah.
Ophthalmologist, orthopedist.
Well, I would say if you have an ophthalmologist as a medical director, I'm not sure they would know about the geriatric medicine that you need to take care of in the facility. I mean, they may know about cataracts and glaucoma and all that type of thing. I would be, and again, it depends, you know. If someone's in a rural area, you may need to have like a non-family physician or a non-internal medicine physician as a medical director. And again, that depends on their background over the years. That's, I'm maybe a little bit concerned about that. So implementation of resident care policies, we'll talk a little bit about that, and coordination of medical care. That's what's in the regulation. Right? And then the dilemma that we have is here And I kind of alluded to this already. While many medical directors also serve as attending physicians, the roles and functions of the medical director are separate from those of attending physician. You can see that medical director is looking at the overall care in the facility, has responsibility for that. So it involves the coordination of facility-wide medical care, while the attending physician's role primarily responsible for the medical care of an individual resident. And something that worries people, worries some medical directors, and if you look more carefully in the regulation, it says medical directors' responsibility is to provide guidance and oversight, not actually develop and implement and evaluate resident care policies, but the guidance and oversight to ensure that that's being done. It's going to be done by you folks. It's going to be done by your DON. It's going to be done by maybe the board of the facility where you are. So let me just go forward here. So I may skip occasional slide as we go through. So what are some examples of resident care policies and procedures? You as administrators, some of you are probably already involved in this, but for Dakota, you're kind of a newbie, I guess. So, admission policies, care procedures, integration of care delivery. So transitions of care is very important. Patients may be long-term care, they go to the hospital, they come to SNF, and go back to long-term care, or they're in the independent living and they go to assisted living on your facility and then eventually into the nursing home. Then the other important thing is, especially for the skilled patients that you take care, is ensuring that they have a safe transition back home. And there are financial penalties / disincentives that are out there that if you send someone home and if they're admitted back to the hospital within 30 days of being discharged from your skilled, you may get to pay back some money because they'll say, well, this would have been prevented had you organized the transition more carefully or being more careful to some of the social aspects, I guess, for example, while they were at the skilled nursing facility. Excuse me. Qualifications of clinical staff, again, for the surveyors, at least the minimal is for surveyors when they come in, they want to know who your medical director is. They want to make sure that their license is up to date. Also, other physicians who are coming to the facility and that they have medical malpractice insurance. Excuse me. So you have access to the slide set, so I'm just going to kind of, again, show that up. So we talked about scope of practice. I alluded to that before. But so your podiatrist has scope of practice. Your ophthalmologist, if they're coming into your facility, is scope of practice. And so as a facility, you are responsible for ensuring that they're practicing within their scope of practice and not beyond. And certainly your medical director would at times perhaps have to be involved with that. Okay. Let's see. And then here, coordination of medical care. And this is within regulation, that second bullet there. Yeah, and this is what the whole survey process is about. Helping residents attain and maintain their highest practicable level of functioning, which includes physical, mental, and psychosocial well-being. And so you can see that it's a team effort, right? It's rehab, it's social work, it's maybe even psychiatry coming in to your facility, other medical healthcare professionals, ombudsmen, surveyors, all that. So let me just, so here is separate from the 4 main roles that the National Medical Director Association looks that I've alluded to already. There's also what's called functions. So what are the functions for the director of nursing? And then under that function is what tasks do they have to be able to do to be able to perform that function. So these are 9 functions. The medical director, 1, administrator. Okay, we talked about that. Excuse me. Professional services, quality assurance, education. Is your medical director doing in-services or maybe informal education to try to explain? I get a call from the nurses sometimes in the past, but these are just examples that they were concerned that someone's on a blood thinner. You do what's called an INR. And the INR is 2.5, which we will say it's high, it's not normal. And they phone me in a panic and say, it's 2.5. What do I need to do? Well, that's exactly where we want it with the medication that they're on. In education, again, this could be a family member, certainly the residents we take care of, the staff, employee health. Sometimes some medical directors may be involved in employee health, depending if they're, like, say, a medical director of a nursing facility, where I was before for a number of years. I would do a kind of a quick 10 or 15-minute employee health education individually. So basically, I wouldn't necessarily listen to their lungs and heart and that type of thing, but I would talk about proper lifting, the importance of getting vaccinations, what the expectation is, that type of thing. And then also the community, both the community within where you are, like Spanish Cove has a big community. So in the sense hopefully your physicians or medical director would be involved in some aspects of, serving the community, but the community can also be outside your facility, outside your CCRC, continuous care retirement community. The community, is Oklahoma City or, Bethany. There may be responsibilities, and again, that's just good PR in a sense. Rights of individuals, certainly within the facility that are residents, and also the right of individuals and people that work in your facility. Okay. Okay, so we have a small group here. I'm ready. Let's see, 1:15 to 2 o'clock. I have infection control. I'm going to keep going for now. Any questions in the room here?
I would still like to go back to the question I asked earlier in regards to the position type. And the reason I ask is because I've been asked to write reference letters for general surgeon to be a medical director for a nursing home. And I'm not sure I want to do that. So I don't know if there's any restriction of that.
Well, I would say, one, your medical director needs to be involved. What are you wanting them to be as far as their duties in the home? Are they going to be looking at policy and procedures, providing guidance and oversight? Are they going to be able to do in-services? Do they know good geriatric medicine? Do they know, and then the MDS is really good geriatrics. It's all function. Do they know what an MDS is? Do they know what QA and PI is? Do they know, some of where healthcare is at this point in time? And some of them,
25% of that,
or that,
maybe 25% of that they would understand.
yeah. Physicians are smart. They can learn stuff. But a lot of this, there's a lot of new stuff coming. It's not an easy job. It's just not coming in for your QA meeting 1 hour a month and just kind of buzzing off. There are other responsibilities. Excuse me. So for example, when I was at QA at Quappy yesterday, I said, as medical director, my understanding and my request, I have asked this, that we periodically have the faculty physicians or the physicians who are practicing and nurse practitioners and PAs in the facility, that we will have a dinner meeting at least once every 6 months or maybe 12 months. And I said, be thinking about this. I like to do it after we clear any kind of deficiency. So if we have survey coming in the next month or two, we'll clear our deficiencies. And then maybe after June or something, we'll have this dinner meeting. And again, obviously it's more difficult with mass, but you can still do meetings. So that I think is an important part. I would encourage you, again, this is up to you, but for them to be at the website for the American Medical Directors Association, the Society for Post-Acute Long-Term Care Medicine. They have a lot of good medical information. They have clinical practice guidelines, which are multidisciplinary on weight loss, hydration, nutrition, heart failure, COPD, Parkinson's disease. So I would just question whether they have maybe all the expertise that's needed. Plus, they have to be a leader, right? They have to be a leader for the other physicians that may be coming into the facility and respected and knowledgeable. And again, that's going to depend on where you are. There may be difficulties getting certain physicians in rural areas, so you may get a general surgeon who's well known in the community, respected. That's fine, and if they've been in practice a long period of time, they're going to know about function. You know, maybe, yeah, that's what it's all about. Whether it's orthopedics or general surgery, is maximizing function. So they may know a lot, but there's a lot of stuff out there. Also, medications, you know, what's appropriate and that type of thing. So
The information you provided was very helpful.
okay, great. Great. So I'm going to move forward. What time do we officially finish at? Is it 3:15 or something?
Whatever you say, sir.
Oh, okay, so I'm good till 7.
Yeah, you're in charge.
Okay, so let's go over the next area. And again, my watch is actually just 5 minutes after my schedule, so I'm doing good. So we'll go forward. So we're going to skip this. We had a question and answer for 5 minutes. So infection prevention and control in post-acute long-term care medicine. Very important area. As I alluded to already, when we had the COVID-19, that was pivotal. And all the facilities were getting the surveyors to come in to see how you were doing infection prevention and control, trying to prevent spread of COVID in your facilities. How many of you have been vaccinated so far? Oh, that's good. They'll get to you down the ladder. I got mine in December because I work in the hospital, nursing home, got to do home visits. I was able to get mine pretty quickly.
You got both of them in December?
I got them 3 weeks apart. I got the Pfizer. Yeah, I got them in December.
We got ours in January. We were told that was the earliest we could get them.
Well, went through the hospital system, the OU Health.
You're high up there.
We were up there big time. We were taking care of a lot of COVID-19 patients. Yeah. In fact, last week we were at 105% capacity. Okay, so there's a lot of infections that occur in the nursing home. Again, this data may be a little bit on the old side because I was looking at this last night. As I said, I've given this talk probably several times in the last 7 or 8 years, and I'm just saying, I'm sure it's more than this. But anyways, there's 150 to 200,000 hospital admissions per year from long-term care. Okay, the average resident has 2 to 4 infections, and you know that could be a dental infection, ear infection, a cough, bronchitis, maybe a urinary tract infection. And again, as I alluded to there, urinary tract infections, respiratory, skin and soft tissue are very common. And I know some people are real critical of doing all these urine tests. I'm kind of in the middle. If the patient's confused, and I've known them for a period of time, I would certainly do a urine test. You'd be really surprised. So, for example, the person that I alluded to had more than 100 W white cells in the urine for high power field. That's what it's called. That's a significant, significant amount of pus cells in the urine that indicates probable infection. And actually that was ordered because there had been he'd been having a little bit more confusion, having some delusions, talking about going to the party, tonight or whatever. And so I said, well, everything else in the lab as far as blood work goes looks pretty good, but knowing what he had, I said, let's go to urine. And, I went and saw him, and he's a little confused, seemed to be doing pretty good. I just saw him today. I had already ordered, I ordered antibiotics today. But I asked, are you having any pain when you urinate? No, I'm not having any pain. It doesn't burn or anything. He probably has a very definite urinary tract infection. Being a male is probably a prostate infection. So there's a different way to handle a UTI versus a prostate infection. It said as of 2020, there are 25% of COVID-19 deaths have occurred in residence nursing facilities. And I think in some states, like I've been hearing it on the radio, like in New York State, I think like 30 or 40% of the deaths they have are people in long-term care. And I also heard on the radio, I think coming down, they're interviewing people, asking them about COVID-19, and they're saying the number of COVID-19 in the nursing home are going down. Okay, but there's probably two reasons for that. One is there's less people in the nursing home right now. Okay, we're probably at 40% or 50% of capacity right now, because people are afraid to come to nursing homes. Plus, people that were going to die have died already of COVID-19. The others have gotten, didn't get it because they were isolated in their rooms, or they now have their COVID-19 immunization. So yeah, it's going down. It's going down related to there's much less people that are in the nursing homes now. So things do change. So, your surgeon would need to be up to date on COVID-19. So provider fighting through the COVID-19 pandemic. Okay, so this is the American Healthcare Association, the nonprofit, have their own magazine called Provider. So it's in there, so I read that, get some good information. So as far as regulations for nursing home, there's an FTAG called 880, and that's looking at infection control, very important, obviously now. But I do remember maybe 15, 18 years ago asking about infection control and how it relates to quality assurance and that type of thing. And the facility wasn't having regular quality assurance meetings at that point. But it's obviously very important. One thing about infection control is, first of all, to be able to prevent infections in the facility. I think one thing that's actually very noticeable is apparently the amount of influenza in the community and in nursing homes has gone way down. Why do you think that is? Because we're wearing masks to prevent getting COVID-19. It's also preventing people from getting the flu. So I'm thinking, well, if COVID-19 goes away, would we still wear masks in the fall to not get the flu? Because usually there's like 50 or 60,000 people that die actually of the flu, separate from heart failure or strokes that occur because someone has the flu. So we'll see. It's obviously an important area. And again, very important for infection control is the resident rights. Do we have the right to isolate people to their room? Or if someone has MRSA or serious type of C. difficile, severe type of diarrhea, do we isolate them in their rooms? We have to have the possibility to do that. So for example, if you have two patients that both have C. diff, you could actually do what's called cohorting, put them in the same room. A lot of nursing homes may have 2 beds per room or something. For our scaled unit, it's 1 bed per room because they changed it, renovated. But for long-term care, it's still 2 beds, unless there's not a resident to put in there. So there are things like that. So that are very important to resident. Okay. So let's see. And then I think you said you're an infection preventionist within the facility where you are. So here's a resource for you. Speak to her about her job. You can learn from each other. We all learn. As a physician, I learn from my patients. I learn how to take care of them. And I learn how to take care of the next patient that comes in the room that may have something similar to them. So what have I learned from the patient I saw a year ago who had this? So we all learn. It's just not a question of seeing another patient. Moving on. Okay. Yeah. Okay, so immunization program. Do you have that for the influenza? How about what did you do for COVID-19? COVID-19 in my facility was you're going to get the vaccination unless there's a medical contraindication to get it. I wish they would do that for the influenza. What I do, and I didn't do it this year because everyone was getting their immunizations. I usually give gift certificates, $50 a piece, 6 drawings, one for 100. You have to be at a certain level. So you probably heard about, having enough people vaccinated to give you that herd immunity. So really for like the flu, you need to get about 60 to 70% of the population in general immunized, get the vaccine to get that herd immunity. And so you probably see that same figure with the COVID, where we're trying to get, 60 to 70% of all individuals in the United States that have that immunization from COVID, so you get that herd immunity. Food safety, pest control, very important. So for example, sometimes I'll get so as a physician who sees patients, I'll get a call from the nurse about, okay, Mrs. Smith, she has diarrhea. They want medication for that. But as medical director, I want to know some things. Are there other residents on that hallway that are having diarrhea? Are there any staff members that have diarrhea? Okay, that's looking at the bigger picture as a medical director. No, it's just that person. Oh yeah, and it's the same thing, things like COVID is very difficult to manage. And then the worst thing that can happen is that if you're having a diarrhea episode or influenza outbreak, is to, you should obviously be in contact, I'm sure you're aware of this, with the Department of Health or the survey agency. Hey, look, we've got this outbreak, we've got it under control, but they're there to help you as well, because they do have access to infection control experts in other areas of the Department of Health that may be able to help you out. Tuberculosis screening, believe it or not, there is an area in the regulation or through CDC to look at whether you're high risk, low risk, or medium risk for a TB outbreak in your facility, and what precautions you might need to do as far as screening. So again, I think there's still 1 or 2 nursing homes in Oklahoma City, at least there's one, that takes care of AIDS patients. So that would be a really high risk for tuberculosis. And I've actually had surveyors come in and say, hey, have you calculated whether you're low, medium, or high risk? And it would depend on what level you're at, what kind of prevention you should be involved in, surveillance as well. At the bottom there, you can see antibiotic review. It's called antibiotic stewardship. Again, that is in the regulations. What the big concern is that we throw antibiotics at people that just have viruses and don't have bacterial infections, is they're going to get resistance to these antibiotics if they happen to get a bacterial infection in the future. And we're having to, have, quote, more and more better antibiotics, but eventually we're going to run out. Eventually the bugs are going to win. That's not going to be fun. Hand hygiene prior to and after all procedures. I mean, even giving this course at the national level, I've learned things that I didn't know before that I thought I did. Excuse me. So, I mean, in theory, you're supposed to wash your hands before you go into a patient's room. And also, if you're wearing gloves, even though you take the gloves off, you should be washing your hands after you take your gloves off. I didn't really realize that in the past. I do now, especially with the surveyors. But you got to be really careful. One instance, we got a deficiency. And again, we all learned, this is several years ago, the physical therapist was doing wound care, and she was doing a great job. She had gloves and everything. And the surveyor was there in the room watching. And then she goes and it's a gloved hand, push the hair back. No, you got a deficiency on that. And you can actually get deficiencies on other people that come into your facility while they're there. They may see, the hospice nurse does not do something right. Surveyors are quite strict in Oklahoma, to what I alluded to before, because the state surveyors never want the federal surveyors to come in after them. The federal surveyors will find things that they perhaps missed. Their federal surveyors are more strict. So just be real careful. I think sometimes they're overly strict. I do remember one time, this was just a few years ago, 3 or 4 years ago, a person came down with a very severe pressure ulcer. It was probably a stage 4, deep tissue. And we went over it and I spoke to them. And it was the surveyor said, well, you did everything right, but they still got the stage 4 pressure ulcer. Well, you can't cite us. We objected to that. How can you cite us? We did everything right as far as the bid, the turning, all this stuff. And, bad outcomes happen. And that you said everything's right, but because it was a bad outcome, we're going to give you deficiency. We actually won that. IDR, informal dispute resolution. Okay, let's see. And then, of course, PPE. I mean, we're all familiar with what PPE is. So as far as infection control, institutional factors can be involved. And I kind of alluded to before, but there's nothing more embarrassing than the Department of Health says, hey, we heard from a family member that you have a diarrhea outbreak or outbreak of influenza in your facility. You don't want that to happen. You want to tell the Department of Health first. Common air circulation, again, a lot of illnesses can be spread through the air, especially TB, right? And then also, there's people coming in and out of the facilities, although perhaps a little bit less now, but once COVID restrictions go away, there's going to be a lot of different visitors coming in that can cause infection in the facility. I think, again, it's all inclusive. So resident factors that increase the risk of infection. So people with cancer or diabetes are less able to fight infection or have increased risk of getting infection. Chronic diseases like rheumatoid arthritis, they're on suppressive medications. Limited physiologic reserve. And again, as we get older, our organs do age over time. And some people may think as we get older, we become more alike. That's not the case. We become more different. So for example, someone may have 60% of their heart function, 20% of their kidney function. Another person may have 30% of their heart function, 20% of their lung function, and then, maybe 60 or 70% of normal kidney function. So that's something that's very challenging. There are certain medications that can result in increased likelihood of getting infected. So the medications that we call PPIs, or proton pump inhibitors, that decrease the acid production in the stomach, are associated with increased risk of infection, even pneumonia and possibly C. difficile diarrhea. So again, there's a lot of things that are going on in our facilities. Common infections, kind of alluded to this before. Again, we'll be looking at that in a little bit. We'll talk about catheters. So we try to get catheters out of people. Okay? It's not uncommon that I think one of the most challenging things I see are people that are discharged from the hospital and they're coming onto the skilled unit and they're discharged on oxygen. Were they on oxygen before they went into the hospital? Never. They're discharged with a Foley catheter in place. So why was it put in? They just didn't take it out when they discharged the patient. So we have to figure out how to get the Foley catheter. There may be reasons why it's there. We often get incomplete medical records from the hospital. Often what I get is the emergency room admission. Well, they were in hospital for 14 days. What else went on? It's really challenging. And of course, some of these are paper, some of these may be electronic. Other things, less common infections to be thinking about are scabies. Someone's having itchiness and excoriations on their skin. You may want to think scabies, or you may want to think shingles, where you get those blisters that occur across what's called a dermatome, either down like an arm or on one side of the body. That may be occurring. So, it's very important as clinicians anyways, that the nurses know in kind of advance what information you're going to need when they call in concerned about these type of things. When we did QAPI, yesterday, were there any MRSA infections? Are there any VRE? No. Okay. Do we have any COVID-19? Nope. Okay. So actually, I think our facility did reasonably well. We had a lot of residents get positive for COVID-19. We put them on the COVID-19 hall, and we didn't have to send any of them to the hospital. But of course, a lot of them were healthy but positive. Luckily, they did okay. Right now, we're COVID-free for staff and residents of the facility. So your infection control preventionists can help you about transmission precautions, whether it's airborne or contact, droplets. You know, with the COVID-19, we're changing people to these multi-dose inhalers rather than these nebulizer liquid treatments because they can result in the COVID-19 going into the air, in which case you'd have to remain out of the room for 2 hours after. Universal precautions basically related to any fluid or waste product. The body can be infectious with blood-containing pathogens like hepatitis, HIV, things like that. So one thing to be careful about, again, I'm just kind of giving you hopefully some helpful information. And again, we learn from our patients. So you can see here, the question is whether is this a real infection or these bacteria growing on tissue that's not an infection, it's kind of like a slime, say, over a wound. And if you do wound cultures and you don't do wound cultures properly, you're going to get a whole bunch of things growing that's really not causing an infection. If there's an infection there, it's probably you're not culturing the right bug. We actually had a case this morning where, let's see, so what I often say, you know, when you're doing a urine sample, I need the urinalysis, which is what the urine looks like under the microscope. And I also need a culture because you can have something growing in the urine, but if you don't have any pus cells in the urine, it's a colonization. That doesn't cause symptoms, doesn't cause illness, and antibiotics would be inappropriate. Okay? So sometimes I'll have the nurses call and they'll say, Dr. Winn, we have a positive culture here. Of course, they're expecting an antibiotic, and I'll go back and I'll say, well, what did the urinalysis show? Oh, we didn't do a urinalysis. Well, I need both. Urine for urinalysis / UA and culture and sensitivity if indicated, because the lab automatically do what's called a reflex culture. If it looks like there's pus cells in there, they'll automatically send it for a culture. But sometimes it can happen that one or the other is done. So we actually had culture come back. It had a bacteria in it. Again, what we look at the what's called the colony count. Okay, is it 10,000? Called a cc of urine, or is it 100,000? We look for what's called usually 100,000. There may be exceptions, especially if someone has a Foley catheter. But it ended up being 10,000 to 50,000. So, you know, well, what do you think is going on? I really like to see that 100,000, but there may be instances when it may be appropriate. And I say, well, let's look at the urine. The urine had 0 to 2 white cells. I said, this is the colonization. This is not an infection. Antibiotics are not indicated. Just did that today. Okay, looking at that. So we got to kind of do it. So antibiotic stewardship. This is part of the conditions of COP conditions of participation. That infection antibiotic stewardship should be part of the infection control program. We have an infection preventionist right here. The goal again is to combat emergence of antibiotic resistance, and I kind of alluded to that. Where I am, we're probably not doing as good a job as looking at antibiotics that are being prescribed and whether they're appropriate. You know, that's something we could do. Move to that later. Okay. So antibiotic stewardship looks at was it really a urinary tract infection? So the one I just mentioned to you, the doctor being on call, they may say, oh, they go right into the urine and not even ask about the urine analysis, the microscope test, and they would have said, yeah, put them on antibiotics. Or if they only have the culture and UA, urinalysis wasn't done, I say, get a urinalysis. Let me know how the patient's doing, if they're having any fever, has there been any change in the mental status. So it talks about doing the right test, make the right diagnosis, the right antibiotic, what's the dose, what's the duration of treatment, that type of thing. Well, actually, when I looked at this, I said, this is for any medication, not for any, just not antibiotics. If someone has high blood pressure or they have heart failure, are we choosing the right medication? Are we giving them the right dose? How long are we going to treat it for? So this example of the 96-year-old that looks like he has a UTI, prostatitis, usually we recommend 28 days of treatment of antibiotics. Well, I was saying to myself, God, he's 96 years old. If I give him 4 weeks antibiotics, I'm concerned he may get this serious infection, the C. diff. So I'm going to give him 14 days of antibiotics. And then the other part was the pharmacist, the PharmD faculty that was with me said, you know, Dr. Winn, we probably need to make an adjustment on this medication because he has renal failure. You know, exactly, instead of twice a day, it should be once a day. So yeah, I've tried to look at you can get what's called an antibiogram, where the hospital will look at what types of bacteria are sensitive and resistant to which antibiotics. And I've tried to look at those. I get the one from Mercy, I get the one from OU, but there's evidence coming up recently that that's probably not, they're probably not really accurate for the organisms that are going to be growing in the long-term care. So there's also what's called criteria. And again, your infection control. Have you looked at some of these criteria here? So yeah. And some of these are more for research than for actual clinical one-person care. But there's various criteria to look at to see, and there may be 3 or 4 different areas in that criteria that would, yeah, this is likely a urinary tract infection. Yes, this is likely a soft tissue infection. Yes, this is likely pneumonia. So there are those that you can just Google those on your phones or on your laptop and look at that. But you need to be consistent with, you know, if you're counting infections in your facility and looking at them, you need to make sure they are real infections. This I already alluded to here, the asymptomatic bacteria, where you need to look both at the urinalysis and the culture and sensitivity and then make recommendations. I've got 10 to 2. Does people here have 10 to 2? That's what I have. Yeah. Yeah. Okay. Okay. Any questions at this point? Are people at home doing okay? Okay. I'm going to talk really briefly about standards of practice, and then we're going to take a break. All right? Because I think the most important thing is what I added. Your agenda is there's 3. On mine, there's 4. That's the quality assurance and performance improvement. I think that is really hidden. That's what we'll get into this sheet here. Okay. So okay, standards of practice. There are various. CFR stands for the Code of Federal Regulations. Okay, that's what they do up in Washington, all these different areas, whether it's long-term care or others. Each one, as I alluded to, beginning physicians, non-physician providers, healthcare workers, usually have their own standards of practice. Standards of practice, overarching principles, really, irrespective of your healthcare discipline, as I alluded to, is this what the surveyors are wanting to look at, is attain and maintain highest practical. Provide person-centered care to respect resident choice, goals of care necessary to ensure resident rights, dignity, autonomy, privacy, socialization, independence, and safety. That's what the surveyors are there to do. And underneath that umbrella is, well, what is occurring that doesn't meet that in your facility? So those are overarching. So remember that. If anything of this section, remember that slide. That's what the surveyors are there to do. That's what we're there to do, of course. The surveyors are checking. So for whom, I just kind of put here, current status of practice are going to be different. If you're an administrator, it's different. Physician, it's different. For ophthalmologist, it's different. For podiatrist, it's different. Right? For general surgery, it's different. For an optometrist, it's different. Ophthalmologist. Something that's very interesting, and some of you are nurses here from a nursing background, is that right? No? Yes. Well, from my understanding is, I remember being on the long-term care facility advisor board at Department of Health. And at that time, there was no CME or what's called CEU requirements for nurses to remain accredited. I think that changed recently, maybe 10 years ago. But at that time, it's very resistant to that. So ongoing education is very important to keep up our standard of practice. And I alluded to this already, ancillary services. You know, if you're wanting to make sure you have a good infection control program, you need to make sure that other people that are coming in your facilities are abiding by what your requirements are. The pharmacist, you know, the dental person, podiatrist, optician, ophthalmologist, x-ray technician that are coming in all the time. You know, are they doing adequate infection prevention when they're coming in? You've got COVID-19 in your building and you're having x-rays done. You don't want someone coming in that's positive and spreading it. Or if they're going from one room to another, you know, are they going to spread any kind of type of infection from resident to another? And let's see, scope of practice. Again, you can read these. I'm going to bore you. I'm boring you already. I'm bore you less. So again, the law allows specific education, experience, and demonstrated competency. Again, a lot of this is related to legislation and then the various society that you may be a member of. Okay, so I'm going to stop there. I have 5 to 2, and let's give you a break, and we'll come back at 5 minutes past 2, so a 10-minute break. Then we'll get into quality assurance performance improvement. Okay?
This conference will now be recorded.
All righty. Let's go ahead and get restarted. The light's at the end of the tunnel. So we're going to talk about quality assurance and performance improvement as it relates to long-term care. Any people in this room where you have been practicing or working, have you been involved in some sort of quality assurance and performance improvement? So I see several people.
I'm certified Six Sigma. I've been used towards MRI and CT.
Okay, well, we're going to have him come and talk about it. All right, that's great. Congratulations. All right, so let's see. Quality on the Rebound, again, articles in Provider Magazine. So that's a good trade journal to get. And I have a disclosure statement here. I've taken some of this material from some of my colleagues who work in medical direction at the national level, very respected. One is Dr. Stephen Levinson. He's in Maryland. There's a Dr. Dallas Nelson as well, Gillespie. And some of the slides that I'm going to present are slides that they gave me permission to use when they had presented some material a few years ago at the national level. Again, the tail that wags the dog, quality assurance and assessment. Code of Federal Regulations. There are various requirements. And again, here, quality assessment and assurance and assessment is the only committee that's required under the Code of Federal Regulations for long-term care. The only committee that's required. You may have other committees that you want, Falls Committee, you may have antibiotic committee, you may have committee to look at restraints, whether they're chemical or physical, but the only committee that you required by regulation to have is quality assurance and assessment. Okay? And again, core membership, if you can look at that, I don't have it on the tip of my tongue, but certainly I think the DON and the infectious preventionist needs to be involved. The administrator, yes or no, should be a healthcare professional, either a physician, could possibly be a physician assistant or nurse practitioner who's basically going to take the place of the medical director, or could even be a non-medical director physician who's in your facility that wants to be involved in QA. And that's great. It doesn't have to necessarily be the medical director, but I think a physician needs to be on. So one thing that's important in improving quality is to basically, that first sentence there, the last word's data. Okay, how would you improve the quality of the care in your facility in an objective manner? It's data. Okay? And we're going to talk about quality measures in a little bit. But again, as we go through, I was just discussing this with a person at the nursing home today, because we did, like last month, we did October, November, December QA together because of all what was going on, the storms. And so yesterday we did the QA for the month of January. Okay, so it's always the month before. We do it once a month. And I was saying, well, you know, we're going through this data as far as pressure ulcers, new antipsychotics, this and that. How does this compare to how we're doing like a year ago or 3 months ago? You've got to compare your data over a period of time. And you also need to look at data, again, the internal data is your facility. You also need to look at what is out there. You know, what is kind of the gold standard or best practice as far as falls in a month in a nursing home or pressure ulcers and that type of thing, because they may give you some guidelines of where you need to aim for. Also, not everything being measured is useful. Where I was a medical director, I guess 25 years ago, facility up in Edmond, one of the nurses said, the head nurse said, you know, we're getting all this data, but we're not using it. So why are we measuring this if we're not going to be using it? Help using it to help change things. And that was legitimate, but we were doing more than the minimum. We were looking at the finances of the facility as quality indicators, you know, looking at, I guess, how much money's in the pot, how much money's coming in, how much money's going out. So it was bigger than, you know, what's required under regulation. We're looking at facility-wide, different areas other than just the care itself. So again, be aware of overlooking important issues not covered by the quality measures. We're going to talk about the quality measures do change over time. And I'll talk about that in a minute. The one important thing about quality assessment and quality improvement is it's a process, it's a structure. So it's not, okay, we're having significant weight loss. Okay, dietitian, it's your job. You're going to take care of that. It has to be multidisciplinary. A good example of this is they're all worried about this patient. I was losing weight. And I said, well, that is significant. So we think this, you know, this supplement and that supplement. And from my medical point of view, well, what could be causing this weight loss? Do they have cancer? Is there something else going on? And actually, the patient had hyperthyroidism, overactive thyroid. That's why they were losing weight. So all this that they were doing wasn't going to help this individual because we didn't have the right diagnosis as far as what's causing the weight loss. So it is a team, and the physicians, they can be involved, whether it's a nurse practitioner or a physician's assistant. need to be aware. Excuse me. Pros for the QQAPI, ensure qualified staff. Look, working with numbers. When you're talking about data, you're talking about numbers. I don't want to scare you away, but this is where it's a very important part of where you're going to be an administrator and facility, quality assessment and performance improvement. Evidence-based, okay, so what is a urinary tract infection? It's not a culture without pus cells. That's not a UTI. Okay, so don't count it as a UTI. Look at cause and effect. And again, we're looking at processes and structures. So structure is kind of the individuals that have their standards of practice working together. And what is a significant outcome? So one of the challenges is quality is, and QAPI, I'm going to say QAPI, is what intervention you decide to do may make things worse. You need to recognize that. So what I'm saying is like just what I just said. Well, the numbers you're giving me yesterday are these, is this worse than before? Show me the numbers from before and I can decide, help you decide what's going on. But the other thing is, it's not an individual, it's a team process. So as I alluded to, weight loss is just not the dietitian. It's looking at the team, helping everyone. Okay, so let's go to this slide, just some terms. And again, this has changed over time. The quality assessment, evaluation, looking, and again, this is the FTAG for QAPI, F880. That's what we were doing many years ago, looking at assessment of outcomes, seeing whether we were satisfied for that. But then the next point is, how can we do better? How can we have less falls? How can we have less pressure ulcers? We have, are we counting number of pressure ulcers in the facility, or are we counting residents with pressure ulcers? The difference. Are we looking at rates? And we'll talk about what rate is. We're going to talk about incidence, prevalence. This is important stuff. This is expected that we're going to be able to do this. This has been done in hospitals for years. People are saying nursing homes even low now, but assisted living to do better. We have tools for you that can help. So quality assurance, I hate slides. Quality assurance is reactive. Okay, what was the outcome? How can we fix that? Performance improvement is proactive. How can we prevent that bad outcome from occurring in the first place? How can we prevent people from falling? How can we prevent people from getting pressure ulcers? How can we prevent adverse outcomes for our SNF patients that come from the hospital on antipsychotics? So there's a process. It's not a question, okay, we had 3 that were antipsychotics. Well, there's a lot behind that. So I'll say, okay, well, these are our numbers, but you need to go back. You need to look back. Can you find out how many of the patients coming onto the skilled unit that are antipsychotic were actually on an antipsychotic before they went in the hospital, before they went in for their hip fracture? Then what can we do now that we see these orders coming from the hospital to get people off the antipsychotic? We need to have more history. And again, I just got a call now with a patient in a nursing home that's on hospice, and the nurse was talking to me and said, we have a behavior problem. You may have a type of dementia called Lewy body dementia, and the attending physician wants to change this benzodiazepine to another one. Hey, that sounds good. And because there's a lot of physical agitation going on, we want to try an antipsychotic. I said, okay, we don't like antipsychotics in nursing homes, right? Because we're going to get dinged on. There has to be a reason for it. There's a danger to the patient / resident or other residents or staff they may be appropriate to use. And I said, well, what dose? The dose is 5 milligrams. That is an excessive dose. okay? I said, you may have heard me on the phone. You really need to call back the doctor and say, hey, you talked to Dr. Winn. We're a little bit concerned that 5 milligrams might be too much, which it is. I would start with 0.5 or 1 milligram, okay? And then the other thing is, the nurse said, well, we think the family says she may have had Lewy body dementia as a cause for dementia. Well, antipsychotics can actually worsen behaviors of people with Lewy body dementia. So I say, well, mention that to the doc. So we've got to be really, really careful. As of yesterday, we had no antipsychotics. Of course, we had less patients too, unfortunately, but everything's kind of slowed down. One controversy about the quality QAPI program is that quality assurance really is confidential. As you may or may not know, physicians who take care of patients in the hospital always have a quality assurance. For our practice, it's once a month. We have clinics, and we have hospital duty as well. So it's confidential. What kind of work and what didn't work? What was there a bad outcome? Could we have done something different? And again, it's not looking at people per se. It's looking at the processes, the structure in place that resulted in this adverse outcome. And that's confidential. So there is a controversy about whether when the surveyors come in, they ask you about your QAPI program, whether they are entitled to see the minutes of the program, because it is confidential. So you might want to have your facility attorney give you an opinion whether what information you could share with the surveyors when they come in. One thing too that they're going to ask when they come in is they're going to ask you about PIP. Familiar with that term? Performance Improvement Project. So under your QAPI, you're supposed to be doing a performance improvement project. And yesterday, for example, I can't quite remember exactly, but they were talking about something, and we can do this, we can do that. And I said, well, that's a perfect thing for the three of you, the MDS coordinator, the DON, and the administrator to get together and work on this, and you call it a PIP, Performance Improvement Project, because they're going to ask you what you're doing. You can say, hey, this is kind of one thing we're doing. So that's kind of it. The expectation is at this point that you're going to be doing PIPs to try to improve areas of concern in the facility. Okay? Right, and just one example, just to kind of, this is, if you go to NGS, CDC website, you can just put QAPI, and they have training programs and information. And this is already owed. I mean, as far as QAPI, you will have kind of already, leadership should say, yeah, we need to do this. This is a requirement. We have the support of the owners of the nursing home, whatever. We have the people that are going to be involved. But looking at systems and monitoring, you mentioned performance improvement projects, and then looking at the results of those. I alluded to before, training is mandatory. And again, you should all be past where you're working. This is stuff that was out there 7-10 years ago. So you should be all on this already. But to stress, if you can't measure it, you can't improve it. That's what I said. Got to look at that. And as I alluded to, as far as disclosures, the state or the secretary may not require disclosure of the records of such committees, except as far as such disclosures related to the compliance of a committee with requirements of the section. So again, so as physicians, when we do our quality assurance, that's protected. There's a rare instance where someone may be able to get information from that if they go to court. Unless you have that, that's even unlikely sometimes. So, as I said, just kind of, you may want to speak to your facility attorneys if they come in specifically asking, well, we want to see the minutes. Basically, you should be asking, tell us about your quality assurance, how do you meet, who's involved, what kind of tips have you been doing. And I think if you get a good tip, I guess it would be okay to show that. But the other thing is, The surveyors come in and they do their surveying, and then you tell them about a PIP, and they say, oh gosh, we didn't see that. You obviously have a problem with pressure ulcers in your facility. They're not supposed to be able to go back and say, we're going to cite you in pressure ulcers. Okay, so that's something to be wary of. That's not supposed to happen. This is the same thing I alluded to before. Again, the design and scope, governance and leadership, that's where we should all be right now. All the other stuff is basic stuff. Okay, so as far as PIPs, facilities set priorities for its own PIP performance improvement activities. So, you know, what's high risk in your facility? It's going to differ from facility to facility. Maybe pressure ulcers for one facility, maybe falls for another. And when we talk about, and we're going to allude to this, when we look at our quality measures, one of them is high risk for pressure ulcers. Okay, it's a quality measure. Who do you think is high risk for pressure ulcer versus, say, a low risk? Yeah, bed bound. Yeah, bed bound. Then low risk for pressure ulcer would be someone that's ambulatory. So if you get a person that's ambulatory getting a pressure ulcer, that's bad. Okay, so they're low risk and they're getting a pressure ulcer. That's not good. So volume, you're getting a lot of pressure ulcers. One thing in our facility, the associate director of nursing was saying, you know, we've had a lot of patients that are confined to their rooms. A lot of them, when they're in their rooms, are staying in bed or just staying in the chair, not moving around. They're in their wheelchair. I'm going to do a skin survey of all the residents in the facility. She found a lot of pressure ulcers. And I'm cringing. I'm saying that if the surveyors come in now and they see what we're doing, but we've taken care of it. But it was quite alarming, actually. But it was something that was very difficult to keep track of everything that was going on. And then it's probably some areas that weren't adequate. So, is this? Sorry, what happened? Oh, yeah, here we are. Sorry for the colors. I need to get this slide changed because I guess if you're looking on your computer, you're going to be able to see it all right. But high risk, you know, high volume, problem-prone areas. Towards the bottom there, it's looking at incidence and prevalence. We're going to talk a little bit about that. And then there's the impact, and basically health outcomes, resident safety, resident autonomy, choice, quality of care. And again, you can see these repeated. These are what the surveyors are looking at, already alluded to. As I said, must conduct distinct performance improvement projects, should be multidisciplinary. Don't want to do a whole lot at the same time. If you're way ahead of the curveball here, you may have one or two going on. But it does say you must include at least annually a project that focuses on high risk or problem performance. So when our surveyors come in the next month or two, they're probably going to ask, well, what kind of PIP have you done in the last year since I guess you could say maybe, or well, we improved our infection control procedures and policy and that type of thing, because that's what they came in a year ago. Survey and looked at, so maybe that would be something to use. All right. So I'm going to move forward here. I'm going to talk a little bit about this, the tools that you may be able to use quality assessment, performance improvement. You know, what is the problem? Who's going to be in the team? In other words, it's just not the dietitian or nutritionist or the person head of the kitchen for the weight. It needs to be multidisciplinary because, you know, to a certain extent, the more people involved, you may come for a better solution, better answers in addressing a problem. So there are questions to ask. So we're talking about RCA, root cause analysis, and the various tools that you can use, the expectation is under CDC, Center for Disease Control and Prevention, even though there's not a P there, it's Center for Disease Control and Prevention. The expectation is you're going to need to know what that means, root cause analysis. And so you certainly need to have buy-in. And again, once you get a result, and here on the bottom there, again, it's here, it's very small, but it's PDSA, it's a plan, do, study, and act, okay? Yeah. And so we're going to show you a cycle. And also related to there, it says adapt, adopt, or abandon. Okay, so some things you may do, you think you're doing better, and actually you're going to do worse. And that's okay. Okay. So this is a pie, I think. You can see there in the inner circle, it says plan, do, check, or steady, and then act. In other words, we're concerned about increased risk, increased pressure ulcers during the month. This looks like it's worse than the previous months, again, comparing data over time. Maybe there's something wrong here that we need to look at. And so, okay, we're going to have a PIP, and we're going to look at our data, and we're going to make a change. See, we kind of go around. Okay, we're going to get better, we're going to get better. Okay, so antipsychotics are at 30%. What can we do? Get them down. Okay, maybe we can get down to 20%. We can get them down to 15. Yeah. So there was a whole initiative about decreasing use of antipsychotic use in long-term care. I'm sure you're aware of that. And for each area of the pie, right, that's why I have the pager. People say, Dr. Winn, why do you have the pager? That's because I can turn it off in a second versus having to take my phone out of my pocket. All my pages automatically go to my phone. So you hear it kind of beeping, what's going on. Certainly when I'm seeing patients, I don't want to have to take my phone out of my pocket. Okay, so again, the various tools, and again, the CDC has tools related to that. Even the QIOs, Quality Improvement Organizations, you familiar with that term, QIO? QIOs have gotten a lot of money over the years for quality assurance and performance improvement in long-term care. And the Oklahoma Foundation for Medical Quality was involved in that for many years. I think about 2 or 3 years ago, the QIO for Oklahoma changed to an organization called Telligem, Telligem. And they actually do have a lot of virtual conference meetings, 1 hour meetings type of thing. A lot of it's being related to COVID-19 recently, but that's the QIO for Oklahoma. They also do Texas and a couple of other states. And they get paid by Medicare. They get what's called scope of work. They get funds from CDC, Medicare, to do QAPI, to train people in long-term care how to do this. So intelligent. You can become members of that, be in contact with them. They can help you out. They don't charge you because they're getting paid by the feds. Their job is to help you, no cost. So, data, there's a book called Data Insanity out there. It's very complicated, very boring. But I labeled this data sanity. So looking at data. So what's going in the data, what's going out, garbage in, garbage out, right? Why are we collecting this information? We're not using it, get rid of it. Talk about incidence, prevalence. We talk about looking at numbers, and we talk about looking at graphs, what are called run charts or flow charts. We look at what's called a fishbone. We'll talk a little bit about that. Just kind of giving you a flavor of things. So you need to have skills and competency related to QAPI and the tools that you can use to go through your improvement projects. Some of this you're going to have to understand. I do, and again, I know it's difficult for Dakota, some of this. I don't know what your background is, but I do remember an administrator that we had once. he wasn't from a healthcare background. He was leading the cooping meeting. And he said, I don't understand this stuff. And he just, like, he went through the cooping meeting in like 20 minutes. CEO of the facility, the CEO of CCRC was saying, no, this is not going to work. Fine. So again, you do have a responsibility to learn this stuff, and hopefully your team will help you if this is kind of new areas to look at. You need to look at the data correctly to be able to decide how to move forward and improving the quality of care in the facilities and maintaining where you are. Okay. So, yeah. So I'm not going to spend too much time on this because I find that when I've given this before, it's like the deer looking at me, staring in the headlights. People get really, really like, oh my God, what's he talking about? So again, it's I'm just going to talk about a couple of things really briefly. So here we have incidents, okay? So this is the number of new whatever events over a period of time. So for long-term care, your facilities, you may want to look at the number of new pressure ulcers that occurred during the month. And it's not the number of pressure ulcers that you had in January, it's the number of new pressure ulcers that you have, new things. Okay, so for example, just yesterday, when we went through the pressure ulcer information, the ADUN was saying, I'm not going to tell you how many, but she basically said, oh, we have that many pressure. No, we have that. This is all the ulcers that we had in the facility. January. The question was, for our QA, we wanted to know number of new pressure ulcers. So you have the number of pressure ulcers in January that were from December, maybe say 10. Then you had 10 new ones. So she was giving us the total, 20, say. Well, that's not what we were looking at. We we're looking at the new pressure ulcers. That's gonna change over time. So another thing you'll see in the bottom of the slide there is, and so as I alluded to before, you can look at pressure ulcers alone, or you can look at residents with pressure ulcers. So if you have 10 pressure ulcers in January, new pressure ulcers in January, let's say for extreme, they're all in one patient, okay? So it would be better to look at also how many patients would have new pressure ulcers. It would be 1 out of 100 rather than 10. So you've got to be really careful when you look at your data and how you define it. Another thing that you may want to do is looking at what's called incidence, okay? And that's sometimes is like 1,000 resident days. So how do you calculate 1,000 resident days? Okay. So for example, say you have 100 patients in your facility and you're looking at February. How many days does February? This month, 28, right? So you have 28 times 100, because there are 100 patients, but each one's there 28 days. So you have 2,800 patient days in the month. Then you can calculate how many pressure ulcers or falls occurred per 1,000 resident days. So the example there is, okay, we've had 30 days, this is September, we have 100 residents, that's 3,000 resident days in September. We had 5 UTIs / in 3,000 resident days in September. And then you divide 5 by 3,000, and you'll see that, excuse me. So we had 0.0017 urinary tract infections per resident per day. Well, come on. So if you want it for 1,000 days, you just multiply that times 1,000. So our rate of UTIs in the month of September was 1.7 UTIs. So the example might be, okay, we had 5 UTIs in, let's say, February of that year, but we only had 50 residents. You can actually see, or in fact, that's what I did with you. So 5 UTIs for census, 50 times 28 days, 5 UTIs per 1,400. Therefore, you can see the number, once you do the division and multiply by 1,000 is 3.6 UTIs. So you have the same number of UTIs. If you say, oh, we had 5 UTIs this month and 5 UTIs that month, does depend on your census. So when they were doing hobby yesterday, I said, well, what was your average daily census during January? Because if you're going to go and look at these numbers, was it adequate? And again, staff turnover is a real challenge in long-term care. I am the one that knows the history of where I am. I've been OU faculty for 30 years. I've been going to this nursing home where I'm a medical director now, not necessarily as medical director from the beginning, but I am now for 30 years. I know it's gone from profit to nonprofit. We're on our third DON in 6 months. Just happened a new one yesterday or the day before. So I know, I'm the one that's been there longer. I know the history of the facility. So that's helpful. But it's like starting all over again. I feel like I'm starting all over again as what I call a newbie medical director when all the staff changes out. All right. So you need to look at the data. So, yep, we already went. I'm sorry, didn't go forward on this. All right, there. Anyways, there's the two. You can go back. If it looks like I'm speaking about something that's not up behind me, let me know. Okay. Okay. So prevalence, total number over a period of time. So when the ADON said we have this many pressure ulcers, or for January, that would be the prevalence. How many new ones plus old ones do we have in the facility? And you can go through those examples again. The thing to be careful about is, are you looking at people with ulcers or people with falls? And again, when we look at falls, how many falls did we have? I think we had 10 falls. Yeah, we had 10. It was 8, maybe 8 or 10. And we go through. Well, who fell? And there was one guy that was there 4 times. And there was one guy that was there 2 times. Well, as another one. So we had basically, there were quote unquote the frequent fallers, right? So when that happens, well, this guy had 4 falls. What's going on? Maybe we need to do something for that individual patient, let alone for the facility, the circumstances of the fall. So it's important to look at that. So I'm going to move forward here. You can read through this. So reports, again, what I want to do here is I want to, and I'm sorry for the people that are on virtual, but as I said, I'll leave copies of what I'm going to discuss now. Okay? This is not the facility where I am, because our census is not as large. I'm going to be looking at this here. Okay? This is a Casper report. And you can Google, you can say, what does the Casper stand for in Casper report? Okay, because I never remember. Anyone here know? Can they remember? But so these are reports that you can print off yourself. Okay, these are reports that you can print off yourself. If you don't know how to do it, the MDS coordinator in the facility should know how to do it. And if they don't know how to do it, the Department of Health Survey Agency can help you do this. There are several types of Casper reports that you can pull off related to your facility. Okay? So what I'd like you to do is to look at a couple of things. So here you have, it says measure description on the left-hand side. And there used to be a lot more quality measures that were being looked at. Okay? Some of them being dropped. So for example, you won't see residents with moderate pain. That apparently we were doing really good on addressing pain. That they said, well, we've kind of maxed out there. We're not required that as a quality measure that's going to be reported, but it's still part of the MDS. So you can see physical restraints, and again, let's see. Oh, yeah, okay. So this is interesting. So when you see like high risk unstageable pressure ulcer, it says bracket L, you know what L stands for? Long stay. So that means the non-skilled patients. Antipsychotic medications, there's an S there. That's a short stay or skilled stay, where Medicare is paying for the rehab. Okay? So you can see what we're looking at. So, and again, CMS ID, the second column, and then has what's called the numerator and the denominator. So if you have a fraction, 1/4, 1/4, what's the numerator? 1/4, what's the numerator? It's the 1. Okay, the denominator is the 4. Right? So you look here, this talks about numerator, which is the NUM, then DENOM stands for denominator. And you can see that the denominator does change, going from 95 to 104, 104, 41, 34, 82, 94, 40, 82, 75, 28. What's the denominator? When is the denominator? What's it related to? I may not be asking that.
Possibly the total pool, total grouping.
To a degree,
There was some classification of 104 denominators, you had 0 physical restraints. So is that patient days, or is that patient admissions, or is that patient episodes, residents?
Yeah, it's looking at your quarterly meetings. Okay, so in other words, of 95 people that had their meetings, like the quarterly versus annual, and between the changing condition, of the 95 that were done, 10 had high risk pressure ulcers. Okay.
Let's say 95 people in the quarter had pressure ulcers.
No,
And
I'm
then-
saying of those who had, the quarterly meetings, what is it called? Say that again? Care plans, right. The quarterly care plans and annual care plans. So 95 people, of the 95 people who had
Half of that.
care plans for the quarter or for the annual, 10 of them triggered for high-risk pressure ulcers. Okay? And then that same thing. So that denominator changes, and then so your numbers are going to change. So here they're looking at, let's say the top one there, high-risk pressure ulcers. If you calculate 10/95, it's going to be 10.5 or 10.5%. Okay, it says facility adjusted, 10.5. Comparison group in the state is saying, well, of all the facilities in the state, 8.4% of care plans are being positive for that. So you're actually doing worse, but you've got 10.5. And it does say that the national average is the 8.9. Okay, so let's look at another one. Antipsychotic medication, long-term stay, L, says 21 of 104 care plans that were done were people who were on antipsychotics, which your facility is at 20%. And in the state, it's at 15, and national level is 14.3. Okay. And then you can see percentile group. So for example, on the antipsychotic medication, it's a national percentile. What do you think national percentile means? So it's ranking you as your facility related to the national average. You can see that you're doing worse. So 80, when you do an exam, you get like 80 or 90 or 100%, you can think, oh, that's great, we're doing better. Well, actually, it's the opposite here. You're looking at percentile. It means 80% of facilities are doing better than you. Okay?
Lower is better than this.
Yeah, more is better.
1 percentile means 99 is less than you. Is that correct?
99 percentile would mean that 99% of facilities with that quality measure are doing better than you. So you're being doing the 1% worse.
So they lower not.
That's right, for the percentile, we're talking about, that's why I'm trying to understand, because,
Versus percentile, you have to reverse those.
well, it's just saying if you're higher on your percentile, that means you're doing worse.
That's right.
Yeah, that means 80% of people with that quality measure are doing better than you.
Versus if you made a 80% of 100, that's not bad.
Yeah, I mean,
Percentile seem to be opposite.
yeah, they kind of are opposite. Yeah, so that's what I'm saying. These reports are available to you. We encourage you to use these reports for your facility to look at these quality measures.
That's why it follows with major injury for long term. They were at the 19 percentile because they had one.
Yeah, I mean, so some of them, like, there's one there that's 97 percentile,
Six.
low risk bowel and bladder incontinence. I mean, 97% of people are doing better than you. So again, this is data, just kind of look at this. The other things I'd like to point out is you can see the report period here. It says April 1, 2020 to September 30, 2020. Okay, so you need to look at your data over a period of time. You don't want to look at your report. You can put this in the computer, either 1 month or 3 months or 6 months. And this one that I got here is what I told my facility to do. 1 month before, it's not going to give me accurate information to be able to make decisions compared to the 6 months preceding. Okay? That's going to give you some helpful information. Now, there's some provisos there that this is for both long-term care and acute care, like the skilled. So there's a combination there as well. So you kind of be wary of that. It all gets mixed in together, which is probably not good in some ways. So you got to be careful. The other thing to be careful about is if you have, so for example, when we're looking at falls and, they're giving me the fall information, they're giving me the pressure ulcer information, they're giving me the UTI information, giving me the antipsychotic information. There's two populations in your facilities likely, right? There's a short stay and there's a long stay. So I'm interested, okay, as far as falls, who's falling? Give me the numbers for the skilled patients, the numbers for long-term care, because it may be a problem just long-term care, not the skilled. But usually, believe it or not, it's the skilled patients that are driving up your falls. So you may have a problem there. It's your skilled patients that are coming in with the antipsychotics. We don't have any long-term care patients on antipsychotics.
Is your length of stay for skilled patients 30 minus 30 average versus your long-term patient? I think your average length of stay is for skilled patients.
Yeah, I mean, it depends whether they're United Healthcare or Medicare HMO. Usually, I mean, it's 2 or 3 weeks probably. Yeah, for the managed care, we talked about that yesterday. And again, they didn't have the exact, but they say usually it's 14 to 21 days. And for non-managed care, it's 21 to maybe 30. And then there's a few that go 6 or 8 weeks or maybe the 100 days or whatever. I mean, I have someone there, I think is going to be there 100 days. Yeah, I mean, that's looked at. Yeah, so there are always differences. So that's basically that information. But this is a more up-to-date one. So just have a look at it. And then also turn the page over. It's another Casper report. It tells you what gender, okay, male versus female. Commonly, 2/3 to 75% are female, right? They live longer than the males. So that's pretty common. You can see in this facility, they didn't have anyone speak of at 20, at age 54. But 50%, almost observed percent, 69% were over age 85. High. So again, when you get compared to other facilities, depending on your patient population, may you look better or worse. Okay, but it does say it says here psychiatric diagnosis. That's interesting. 105 over 169. Now that could be anxiety, could be depression. We know that we undertreat depression, and we also overtreated medication probably. You can see they had hospice 26 out of 173. So that's going to be different. But that kind of give you an idea of what's going on in your facility. And that can certainly change over time. And again, that's another Casper report.
I'm sorry, doctor.
Yeah.
Can you explain the denominator change in the diagnostic characteristics? Why that, the study group changed? Because I read the denominator as a study group. They looked at 173 records, 44 were male, 129 were female. We look at the psychiatric diagnosis, intellectual development disability, or hospice, numbers don't tie out.
And again, each facility is going to be different. So again, yeah. So I mean, basically, most of those numbers are, other than the psychiatric diagnoses, most of the numbers are all at the 170, 173 residents. So yeah, there's maybe a little bit discrepancy there. So what was going on? Was there something? Was the data not put in right or something like that? Again, this is all generated by the MDS, the minimum data. So yeah, you're right. That kind of
Let's
looks a
assume
little bit unusual.
105 of your 173 studied were had psychiatric diagnosis.
Yeah. Well, remember, there's not major psychiatric diagnosis, insomnia, anxiety, depression. And remember, some of these medications that we use for depression aren't for depression. They may be for chronic pain or peripheral neuropathy. So they will automatically kind of be put in the wrong slot, shall we say. So again, just kind of have to be inquisitive. Okay. So just kind of, these should be able, your MDS person should be bringing these to do your copy. Encourage you to look at that. Because this information, what do you think the surveyors do? The surveyors look at this information a week or 2 weeks before they're coming into your facility. They're going to know, oh, this is high in pressure ulcers. This is high in falls. They're going to know. And then actually, I have it here. I won't show it. This is not my facility. But actually, then you can get everyone that triggers for these quality measures. You can have each resident, and it will show you which one they trigger for. Someone for none, some for 2 or 3, some for 5 or 6. You've got someone triggering on quality measures 3 or 4 or 5 or 6. You need to be looking at that resident. Now, some of them may have already gone, right? Because if they were on the skilled unit, they may have already left the facility when you're looking back 6 months. But you can actually, go further into the data and look at the data. But so the surveyors are going to be able to know when they come in, oh, Mrs. Jones, she's been triggering for this, 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 and that. Oh, and she's still here. Let's go see her. Okay. So, and then just kind of as a heads up, I hate to say this, it's his physician's fault. So the AMA, American Medical Association, there were several reports of concern about the quality of care in nursing homes. This goes back 30 years. And they did a report. That's where it all started. That you have kind of a minimum data set, which changes over time. It's good geriatrics. So that was put together. And so that was looked at, and they knew, I mean, this is 30 years ago, this Nursing Home Reform Act. I think it was in 1973 or something like that, 74. So AMA was the main impetus for that passing Congress. And they knew that eventually, when looking at the minimum data set and the data, they eventually said, we're going to be able to use this for quality improvement. They were thinking of this 25 years ago. That's where it came, basically, let's say 10 or 15 years ago, we reached that, looking at quality improvement. And then they said, if you're doing better, you're going to get paid more. Eventually, we're going to use that quality improvement data to improve payment for good people, doing well, good facilities doing well, and those not doing was all going to get less. So that's all being said. It was very futuristic. I kind of mentioned that book up front, and so a lot of this was already going on. They had the idea that we're going from doing the minimum data set, using that information to look at quality, using that quality information to pay. Okay. So people want better outcomes. patient satisfaction, less time in the SNF, right? And then get adequately reimbursed for doing a good job. So that's all. So I'm not going to, this is, I'm just going to briefly show this. This was Texas Medical Foundation. They were the one, the QIO recently. They lost the contract to CMS for, and then Intelligent is the one that has it now. So basically, what it's showing is they're looking at quality measures. There's ones that are green that you're doing good. There's ones that yellow weren't doing as good. Ones that are red, you're not really bad. You need to look at it. And so they would calculate a score looking, statistically at all these quality measures, how your facility is doing. And you can say in this facility, and again, this is data that's no longer available. You can see it's 2016. In fact, I think they used it to 2018, but this is one actually from my facility, where our score was 17.99 or almost 18. And you can see that over a period of time, on the right-hand side, we got our score down to 6.2, and the average you were aiming for was 6. So the new QIO, the Intelligence, not using this, but I didn't take this slide out. It's other ways that you can look at information, but it's not available anymore. I thought it was pretty good. Okay, so let me go ahead here. Okay, so line graphs, basically you're looking at data over a period of time, okay? So I'm going to keep us on time. So I only have to like 3:50. You can see my page is going off like crazy. So this is what I kind of alluded to before. This is looking at, it says falls per over a period of time. Basically, looks like a little bit over a year. Starts in January on the left side, goes to March of the next year. And that you actually have falls, and you can see on, and again, for those people that are virtual, on the left-hand side, going up on the side, it says falls per 1,000 resident days. And you can see unit A, B, and C. You can see they're all kind of coming down, but some units are higher than others. So it may be, again, skilled patient data may skew the overall data. That's why you sometimes need to look at skilled and non-skilled, short stay and non-stay. You may have to look at skilled unit A and skilled unit B, because there may be differences explaining why you're doing as well or not as well. So again, just kind of to give you just yeah. So I'd say what to monitor: hospitalizations, rehospitalizations. I mean, the hospitals that are sending people to your facility for skilled care, they don't want to see those patients back in the hospital. And if they're going back in the hospital, you may not be a preferred provider for them. That was all going on like 2 or 3 years ago. All the hospital systems trying to identify preferred providers. Pressure ulcers as well. Operations data, again, this is look at staff turnover. We have been looking at that before, but that's kind of fallen by the wayside because the person that was doing that is left. I guess no one has really taken it up. They look at that overall, but they're not reporting it to the QAPI anymore. You don't have to, but that would be something I would want to ask about. Call bell response times. Surveyors come into your building, they're going to be ringing those call bells and standing there in the hall and see how long it takes someone to come down. Already alluded to some of this. So never events, code status, wrong code status, wrong diet consistency. Again, some are more serious than others, but certainly the diet consistency wasn't correct for that person and they end up choking again. That's not something you want to have. Wrong medication, elopement, those type of things. Surveyors are going to come in and look at that. Members of the QA, for example, you know that the pharmacies, long-term care pharmacies that provide medications to your facilities, they do have a Form D come through, look at all the medications, monthly medication review. We have that person come to our QAPI meeting every quarter. She was there yesterday. And I think they're obligated to give us a report. And the other thing would be, okay, the surveyors are coming, is there anything we need to be aware of that haven't reported to us at this point? So again, not everyone needs to be a QA committee. And the other thing is that you should, if you're working on your PIPs and quality assurance, it doesn't have to occur in or by the QA committee, but it needs to be reported to. You don't need to have all 10 people at the QA committee working on weight reduction or falls. Have 2 or 3 at a team. And that team should be doing all the legwork, doing the PIP, and bringing their findings back to you. Okay? So let's do some fun. We're almost there. Okay, so we're going to look at medication error rate. So you can see the months there on the bottom, going from month 1, which may say be January, to month 25, which is January 2 years down the road. Okay, and we're looking at number of errors on the left-hand side. The X is going up, and it's going like from 15 to 35. Now, the other thing you need to be careful about, so there's a little bit of a trick. Okay, where's 1 to 15? So you got to be really careful when you're looking at that. So, but again, I guess there was no time when it was less than 15, so they just kind of started there. Okay, so we can see in the first couple of months there, it went from 21 to 31. You can see that? People hopefully are not sleeping at their laptops. And okay, and then we can see in the next one, we'll just kind of go forward. So we're collecting data over time. That's where you can make good analysis of what's going on. So you can see it's kind of gone up and then down and up a bit. So there may be some variation that's occurring here, but is it significant or not? Okay. All right. And then we come here to this. So we got it down to 19 and 13th or 14th month over this 2-year period, and then it kind of goes up again. And then we get this one here. So this one here, the question is, if you had an intervention when the dip was really low there, when in the middle, the dip way down, like that, was there anything that you did to get it down that low? And then perhaps what happened when it started to go up again? Right? So what we're looking at, in a sense, is what's possibly called common cause variation, or is it a specific variation? For these falls, was there a problem not having enough physical therapy or not having enough nurse aides to help ambulate the patients, so they're getting deconditioned and falling? What's going on to help explain this data? So that's where you need to kind of look through. So it kind of looks variable. It's kind of up and down. So, and then, so this is the same graph. Is at 50 people, okay? And you have them flip a coin 25 times, which is 1 through 25, and the number that is heads. And so a coin toss is what? Variable, right? So you can see all this stuff was varying month to month. It was just common cause variation. Didn't mean anything. So if you were on the left-hand side doing something and it kind of got better, doesn't necessarily mean anything changed. So it basically gets into common cause or special cause variation. So you need to be aware of that. So if all of a sudden your pressure ulcer rate goes up, it may just be a common cause variation. You don't need to do anything. Just see what happens the next month. Okay. And then, because if if you make changes when it's going up, you may actually make it worse. You may actually keep going up. So again, it's just to be aware of that. So that means basically you have to look at your data over a period of time. So if you've got 2 points of data and one's down here and one's up here, doesn't mean anything, right? Because it could just be common cause variation. And some people could be really sophisticated about this. They could look at what's called mean and median data. People understand the difference between mean and median. Okay, so the mean is the average. So you add all these numbers up. And so, for example, I was at a hotel last week, Friday to Friday, because of the weather. It was hospital duty. So my hotel rate, I think, was like 120 for the first 3 days, and then it went up to 140 for the last 4 days. So I would average, like 3 times 120, 4 times 130 or 40, and then add them all together and divide by 7. That would give me the average. Okay, the average. The median means that when you have a set of data points that 50% are below a certain level and 50% are above. So it is different. Okay? So again, you may come across those terms as well when you're looking at data for your quality. That's the kind of the simple aspect. Okay. Oh, yeah, this is good. We're getting there. It's got a few more. Okay, so here we are. Looking at the left-hand side, and again, the people on the looking. Where? Oh, no. Where am I? Oh, there we go. Oh, I got to speak up. So the mic. So here, this is kind of similar to the flip, right? Looking at common cause variation, and this actually is either a mean or this could be a median. Here it says median. Okay. So 50% below, 50% above. So we can just see it's kind of going up and down. This is common cause variation. You're going from here to here. Don't get excited. It just may be common cause variation. Okay? Not significant. But if all of a sudden this line here moves up here, okay, there's a change going from this to this up here. Okay? That's special cause. So you want to look at it and see what's going on. And sometimes it may just be staffing, or you have a new deal, or you don't have a deal. So that's where the data. Again, if you just look at numbers, you may be able, some people are more visual than others. So you see something visual, that's helpful. We look at numbers where I am, they're not charting it. I say, you need to chart this stuff because I don't remember what we necessarily have the month before. It's got to be presented properly. Then there's another tool called the YYY. And by the time you get to the 5th Y, so for example, a person falls. Okay, so they had a fall. Why did they fall? Well, they have had a knee replacement. And if they had a knee replacement, that increases the risk of falling. But where they fell out of their transfer from the bed to the wheelchair. Well, why would that occur? Was it unassisted? We need to, okay, there was no person there to assist with that. Well, why did that happen? Well, they didn't push the bell or the page to have the nurse come and help them transfer. And why wasn't the nurse available to do that? Well, they were out having their smoke break type of thing. And so again, it's on an individual, but certainly on a group of things, a group of falls. Why are we having so many falls? And again, you can look at the individual patient, like you can look at the big picture. By the time you get to the 5th Y, you're kind of into kind of what's going on. So that's one tool that's being used. My facility uses that. And here's what's called the wishbone. And you can see there's various categories there. Sorry, I just have a small picture. So one is equipment, was the poor outcome on the right-hand side. And we want to improve the poor outcome. So was it a staff issue? Was it process of care? Was there something wrong with the equipment? Was it the materials? Again, if we have pressure ulcers, we have the right materials to prevent pressure ulcers or treat them. Do we have enough training? of the staff. So, you know, are they getting the Norton score, that other scores to look at risk and management? Do we not have the money, the supplies to be able to do a good wound care? Again, this is kind of a framework you could use for maybe any core outcome that you have. And then under each one, you see those other arrows, it kind of gives you more information. Well, what was wrong with it? Well, our hardware lift was broken. Or number two, the people didn't know how to use the hardware. So, you know, you can go on and on, like an arrow, like a feather. So that is one thing you can use as well. And here's one here. It's just an example looking at urinary tract infections. One, poor outcome, high rate of urinary tract infections, triggered quality measure on Casper report. Okay, so nursing, technology, families, procedures, physicians, education. So you can, how are we going to improve this? It's just not one thing. It's various areas you need to look at. Right? And I think we started with one butterfly at the beginning of QA, and now we're taking off, and you're going to be able to do some of this. So I don't want to scare you. This is where, you know, you're going to have different levels of proficiency depending on the facilities where you are. But there is expectations that you start the basic stuff and go from there. And for you facilities to get the reimbursement they want to get, they're going to need to work on this. Because if you're doing bad in some of your quality measures, they, you know, at least the hospitals are not going to refer to your facilities. And the other thing to look at is that probably C. So the other thing to look at is nursing home compare. You familiar with that? You need to Google nursing home compare, and it will take you to the CMS website. You can put in your facility location, and you'll be able to see how many stars you get, okay, for surveys, for quality measures, for staffing, okay? So we kind of did okay on surveys. We got like a 3. For quality measures, we got a 5-star. For staffing, for nurses, RN staffing, I think it was, we got 4. And so that would pushed us up into actually a 5-star. I don't remember ever having been a 5-star. I was surprised. I asked them is that really us, 5-star? Yeah, that's us. Well, I don't know. I think that may change because there's a lot of things that have gone on over COVID. But anyway, that's what I have to say. Thanks for being here. Thanks for you folks on virtual. Good luck. I'm willing to stay. I'm over, Z. I'm willing to stay for a few minutes if you have questions, but otherwise have a good day and good luck on your course.